Hi, we will get started in a few minutes.
Good morning. Thank you so much.
Hi, everyone. Thanks for joining today. We're going to go ahead and get started. I'm going to introduce our speaker, Dr. Ashley Darcy Mahoney, who's a neonatal nurse practitioner and researcher and has worked throughout her career to advance nursing research, education, and practice with a focus on neonatology, infant health, and developmental pediatrics. Her research has led to the creation of programs that improve health and developmental outcomes for at-risk and preterm infants. As an associate professor of nursing at the director of infant research at the George Washington University's Autism and Neurodevelopment Disorders Institute, Dr. Darcy Mahoney advances the body of research in infant health and developmental outcomes in high-risk infants with a focus on understanding the early brain and developmental trajectories in this population. In addition to her work with the Institute, she conducts interdisciplinary research through Talk With Me Baby, a multi-agency initiative using the nursing workforce to educate parents in the importance of talking and engaging with their babies in early infancy. Her research seeks to improve early childhood outcome for these infants, most recently through language interventions that improve future literacy and cognitive development. Dr. Darcy Mahoney is a Robert Wood Johnson Nurse Faculty Scholar, and with her most recent grant from the RWJ Foundation, she is pursuing outcomes research in preterm infants by comparing developmental trajectories of children raised in a bilingual environment against those raised in a monolingual environment. She's a fellow of the American Academy of Nurses, a 2017 Josiah Macy Scholar, and was named the top 25 pediatric nursing professors by NursePractitionerSchools.com, and has earned numerous awards, including the 2014 March of Dimes Nurse of the Year, Florida Association of Neonatal Nurses President's Award, and the Lillian Schultes Bruner Award for Innovation from her alma mater, the University of Pennsylvania. So with that, we are going to get started.
Hi everyone, I am so excited to be with you today. My name is Ashley Darcy Mahoney, and I'm an associate professor at George Washington University, and I am the former National Academy of Medicine Nurse Scholar in Residence, where I worked for quite a while on the new report entitled The Future of Nursing, Charting a Path to Health Equity, which is what we're going to talk about today. So Throughout this presentation, I'll refer you back to that report and many interactive opportunities that we have to engage with the report, from previously recorded webinars and Twitter chats to podcasts. So there's lots of opportunities to engage with this report beyond what I'm going to talk about today. So today I'm going to give you as in-depth of an overview as I can for the next 45 minutes, knowing that this report is over 500 pages long. So I hope to give you a really solid overview of this report, and I hope you'll see how it'll impact your care of kids and how you can begin to advocate for them and for nursing to really be a powerful force for health equity. So why health equity? For too long, the United States has overinvested in treating illness and underinvested in promoting health and well-being and preventing disease. Despite significant financial investments in our healthcare system, the health of Americans lags behind other countries. Compared to most other developed countries, life expectancy, infant mortality, and maternal mortality are all worse in the United States. And while COVID-19 has illuminated and exacerbated health equities, the United States faced wide and persistent gaps in health tied to poverty, racism, and place well before the pandemic hit. Our race and ethnicity, income level, sexual orientation, immigration status, access to health insurance, and the conditions of our neighborhoods predict whether we will experience preventable, costly medical conditions, live shorter lives, and have a fair and just opportunity to be healthy and well. Understanding the roots of these inequities and the role that housing, transportation, kind of job you have, the conditions of your neighborhood, and other social determinants of health play will help us improve everyone's health and well-being. Racism in all of its forms increasingly acknowledged and understood as a key factor that affects how long and well people live. In this report, we focus on 3 different types of racism: structural racism, cultural racism, and discrimination. I'll let you all read these for yourselves. I won't read slides to you today, but in the nursing community writ large, racism, discrimination, and dehumanizing attitudes on the basis of race, ethnicity, gender, sexual preference, and more from employers, educators, managers, colleagues, and patients are omnipresent. Black nurses have long reported encountering racism at work and in school. There's an uptick in Asian nurses reporting verbal and physical attacks amid COVID-19. LGBTQ nurses have reported discrimination and harassment. We take this on in this Future of Nursing report is in a really robust way. We recognize that there's much more to do, and we hope that this is the beginning of the conversation to really change the way in which we talk and think about racism in nursing. We recognize that it's not the end point, and we recognize there's much work to do. So we hope that in this report we start the conversation, but that there's a much more extensive conversation to be had. Try to really bring forward some recommendations to that effect. It is clear that nurses can and should do more to build healthy communities for all. Future of Nursing 2020-2030 Consensus Report builds on the progress that we've made over the past decade since the Institute of Medicine produced the Leading Change Advancing Health report, which you can see here. We have strengthened advanced practice, promoted leadership, and increased diversity, but we haven't gone far enough, and thus is where this new report comes in to move us forward into the next decade. The new report, funded by the Robert Wood Johnson Foundation, is a product of the National Academy of Medicine and its committee of 15 experts in nursing, leadership, practice, education, and workforce, as well as health policy, economics, medicine, law, and healthcare research. Mary Wakefield and David Williams co-chaired the committee. It met 8 times, including 2 sessions open to the public, and committee members conducted town halls and in-person town halls in 2019 prior to the COVID-19 pandemic. The foundation tasked the committee with charting a path for the nursing profession to create a culture of health to reduce health disparities, and to improve health and well-being for our nation. The committee reviewed existing literature and evidence from the field, data and analyses from partners, papers that were commissioned for the study, and public statements about the committee's task to craft the report and its recommendations. A team of study staff from the National Academy of Medicine and a group of advisors supported this committee and this work, which is where I come in. So I was not a member of this committee. This report reflects the committee's writing and the committee's consensus reports, and I helped support staff edit from there, as well as all of the people here that you see, including members of the team that are nurses and members of the team, as I mentioned, that were not nurses. The COVID-19 pandemic, which began as the committee was drafting this report, compelled the committee to highlight nurses' pivotal role during the pandemic. And it actually made us delay the report coming out for about 8 months to make sure that we included appropriate evidence and consensus around nurses' role during the pandemic and nurses' mental health and well-being, disaster preparedness, including the widening inequities in health. So, what's in the report? The new report first and foremost recognizes that promoting health and well-being for all has long been an essential role for nurses. The reason is simple. Nurses are everywhere. In clinics, ICUs, schools, homes, and on front lines of disasters. As the largest and consistently most trusted segment of the workforce, nurses are well suited to help our country advance health equity. We are bridge builders, collaborators. We engage and connect with people, communities, and organizations to ensure people from all backgrounds have what they need to be healthy and well. For instance, school nurse works with teachers, school staff, and leadership, as well as parents and students, to make sure that a child is healthy, well, and supported. And when a nurse is working in a hospital, they often look beyond vital signs and physical symptoms in an exam room to understand what influences health and the community that that patient will go home to. Take nurses at Rush University Medical Center in Chicago, who helped found an initiative that repackages unused food from hospitals to distribute meals to members of the community experiencing food insecurity. But nurses need more support from systems that educate, pay, employ, and enable us to continue this critical work. Across the board, we need to truly value nurses and the work we do in order to keep us all healthy and well. There are 4 key actions that the Future of Nursing report lays out, which I'll walk through in detail today. First, permanently removing barriers. We mean this across all different levels of nursing. In the first report, we talked quite a bit about advanced practice nurses. In this report, we talk about removing barriers for all nurses. Valuing nurses' contributions, both valuing it from a personal perspective and a professional perspective, but also what does that value mean in terms of valuing various payment models that support what nurses do every day. Preparing nurses to advance health equity, what can and should we be doing in both continuing education and in undergraduate, master's, and doctoral programs to advance health equity? How are we diversifying the workforce? How can we make sure that more nurses look like the community in which we serve? To start, I'm going to talk about how we can permanently remove barriers that stand in the way of nurses at all levels and in all settings. Whether a nurse is managing a clinic or making home visits, they face barriers every day. Everyone, no matter who they are or where they live, needs access to high quality, affordable healthcare and opportunities to be healthy and well. More than 80 million people, around 1/4 of this country, live in an area with a shortage of health professionals. By 2033, current physician shortages will continue to increase, particularly in the areas of primary care, mental health, and gerontology, especially in rural areas. Nurses at all levels and in all settings have education, skills, experience, and training to fill this critical gap and address health disparities, if given the autonomy and institutional support to do so. Nurses currently face 2 types of barriers: those relating to scope of practice, which can be lifted through policy changes, many of which we've seen during COVID-19, and institutional ones that affect where nurses are working, learning, and training. Again, many of which have been lifted, changed, adopted during the COVID-19 pandemic. So to start, we'll begin with scope of practice. Scope of practice refers to what a healthcare provider is allowed to do for a patient, keeping in mind their education, training, and professional license. This report looks extensively at what it means to expand scope of practice for advanced practice registered nurses, which includes nurse practitioners. Expanding scope of practice for advanced practice registered nurses allows us, I am a nurse practitioner, to prescribe, diagnose patients, and treat independently of a physician. The issue, though we have education and training to administer this care, all advanced practice registered nurses don't have this level of autonomy. It varies by state, district, and sometimes locality. Considering the severe physician shortage our country is experiencing and potentially will experience, expanding the scope of practice for advanced practice registered nurses significantly increases access to care, particularly in underserved communities. Evidence also does not show that the scope of practice restrictions improve quality of care. These regulations limit competition and contribute to higher costs. In fact, during the pandemic, 8 states expanded scope of practice for nurse practitioners so that more people could access care. But as you can see from this map, 27 states, more than half the country, still restrict full practice authority for nurse practitioners. In 16 states, nurse practitioners need physician's authority to prescribe medication, and in 11 states, they require physician oversight for full practice. Here's another example of how expanding scope of practice optimizes care. To address the opioid crisis, a 2017 federal waiver allowed nurse practitioners and physician assistants to prescribe buprenorphine, a move that significantly increased access to care in some rural areas and kept many more people experiencing addiction safe. Until all advanced practice registered nurses are permitted to practice to the full extent of their education and training, significant and preventable gaps in access will continue. Nurses at all levels and in all settings face institutional barriers to fully leverage their skills to advance health equity. These range from restrictions on providing telehealth services to the workplace that prevent them from providing optimal care. These institutional barriers can start when prospective nurses are starting school. Students from underrepresented backgrounds, people of color, those with low incomes, first-generation students, LGBTQ students, may need support in a number of areas as they go through programs. They may face financial barriers to attending programs, or they may need social and academic support to thrive. Well before the pandemic hit, many of the country's 4 million nurses had physical and mental health burdens tied to their jobs. In the workplace, many nurses face institutional barriers that contribute to burnout, that hinder their ability to do our jobs well. Organizations that employ nurses don't always have mental health support or adequate resources, from enough staff to adequate PPE. Another example that rose to the forefront amid COVID. Before the pandemic, nurses were not allowed to bill for telehealth services. During the crisis, however, the Center for Medicare and Medicaid Services temporarily broadened access for Medicare beneficiaries. Nurse practitioners and other health professionals have used telehealth to screen people for COVID-19 and treat non-critical illness that can be managed at home. It has also helped maintain a robust workforce to make sure people could access care when they need it. NPs who've had to quarantine due to COVID-19 exposure have still been able to work and provide care for people using telehealth services. To address these barriers that we just reviewed, the NAM report recommends that policymakers expand the scope of practice for advanced practice registered nurses, including nurse practitioners. Federal authority should be used to supersede restrictive state laws, as has been done in the VA health system. By 2022, all related changes in policies and state and federal laws adopted in response to COVID-19 should be made permanent. We've seen over the past year that these changes work and have not impacted patient quality, care, and safety, but rather increased access. Employers and government agencies need to remove institutional barriers such as telehealth restrictive and restrictive workplace policies. The evidence shows that these actions will help expand and improve access to care for communities and people across the United States, particularly those who've experienced limited access to healthcare and public health services. So, how can we better value nurses' contributions to health equity? Oftentimes, many of the scope of practice issues that we've seen are tied back to funding. How we fund nurses and nurse practitioners are a big reason why and how we can expand access. As the committee found, the U.S. healthcare system does not value addressing social determinants of health nor advancing health equity. It's designed to pay for quantity, not necessarily quality of care, although we've seen some changes more recently. To treat existing illnesses but not prevent them is something that we're often paid for more. And we often prioritize hospital and specialty care over primary and preventative care in our payment models. This model has contributed to deepening disparities and disproportionately impacting people of color, those members of the LGBTQ community, those with low income, and those living in rural areas, in addition to many others. Nurses can help change this. Again, as the largest and most trusted workforce, we bring immense value in providing care from hospitals to the community settings. But without strong financial and institutional support, our reach and impact are limited. How care is paid for often determines one's access to quality of care. There are two actions that we discussed in the NAM report for achieving this goal. Number one, reforming payment models, which I'll discuss, and valuing community and public health nursing. The current healthcare payment system prioritizes volume of care and underestimates the value nurses bring in addressing obstacles to good health, such as poverty and discrimination, and in expanding access to care. The work that nurses do, the work we do, much of which addresses social determinants of health. In kids, it addresses food insecurity. We may address housing. We may address school, behavioral, mental health, social, emotional concerns. This is often under-recognized and undervalued. For example, payment systems often reimburse physician services, excluding services of other providers, including nurses and team-based care. Advanced practice registered nurses are reimbursed at 80 to 85%, compared with full reimbursement that physicians receive under their fee schedule. And in 2014, the federal government rescinded a policy that prevented school nurses, the lifeline for so many children and families, from billing Medicaid for their services. In 2019, 7 states had made changes to Medicaid policies to then go back and allow school nurses to bill, an important policy change that affects how school nurses practice and how they can extend their services to all children. And importantly, how that money then isn't taken often from a school board or school education system to fund school nurses, but rather it's funded through health and insurance mechanisms. Even so, the billing process is complicated, and this often prevents many school nurses and school systems from taking advantage of this policy. Most nurses are also unable to bill for telehealth services, as I mentioned earlier. This only shifted for some during the COVID-19 pandemic. So how do we fix this? Value-based payment models and alternative payment models such as accountable care organizations and accountable health communities link quality of services and value, thus focusing on outcomes that can advance health equity. The events of the past year have made us acutely aware that we need to do more to support community and public health nursing so that we can all be healthy and well. School nurses in particular play a vital role to healthy communities. They can detect illnesses, help manage chronic conditions, and contact trace outbreaks during a pandemic. They also provide mental health care, a need that has tremendously grown during the pandemic among young people. The demand for these services has grown exponentially as a result of COVID. School nurses are a lifeline for 56 million students, particularly students from low-income families, rural health communities, and places that have low access to care. But today, 1 in 4 schools do not employ a school nurse. In fact, the NAM report showed that the average school nurse works simultaneously across 3 schools, and funding sometimes must be pieced together. The gap exists despite the evidence that the money invested in school health services reaps real benefits. One study in Massachusetts, for example, found that for every dollar invested in school health services, it yielded $2.20 in savings per student in avoided medical procedures and lost productivity for teachers and parents. A good example of how school and public health services are a natural bridge builders to healthy communities is the work of Robin Cogan, a school nurse in Camden, New Jersey. She has long seen the role that systems and factors like being from a low-income family, lacking nutrition, and stable housing has on a child's health and well-being. After working for change in her own school, Cogan partnered with fellow school nurses and public health officials in the region to understand what local parents need. They started community cafes, an initiative to hear directly from families about the challenges they face. These conversations have led to work with local healthcare providers and discussions on topics ranging from an immigrant's experience to a father's role in children's lives. This work has shown the powerful role that school nurses play in reforming health systems to foster healthier communities. Public and private payers need to establish flexible and sustainable payment models to support nurses in healthcare and in public health. This includes school nurses, a group that consistently undervalued and underutilized. And specific steps need to be taken. And many of these are sort of extensively discussed in the report. So I'm going to highlight them at sort of the bullet point level. But if you want to dig deeper in, we'll find them in the report a bit more. Reforming and embracing different payment models. Enabling nurses to bill for telehealth services. Centering performance measures on health equity. And adequately funding school nurses and public health nurses. Something that has become much more acutely aware of, and we've seen in the American Rescue Plan funding set aside for school nurses. This report's central theme on how to help nurses carve a path to health equity. This is sort of really where we focus in this report and where really everything stems from. How can we better prepare nurses to do this? How can we better prepare nurses to help the country achieve health equity? The truth is that nurses at all levels and in all settings are not fully prepared to advance health equity for all. Preparing them to address the evolving health, social, and economic needs of their communities should take many forms. The report covers 3 main areas that we need to do to help prepare nurses. Number 1, transforming nursing education. Number 2, preparing nurses to respond to disasters and public health emergencies. And number 3, fostering nurse well-being. The pandemic has reinforced that all nurses, regardless of where they practice, should possess deep, empathetic, real-world knowledge and understanding of the social, economic, and environmental factors that affect health and well-being. Many nurses are not taught about this in the classroom or clinical setting. Most nursing schools cover health equity and social determinants of health as a siloed topic, leaving nurses underprepared to work in a wide variety of settings and with people from diverse backgrounds and diverse needs. There's also significant shortage of faculty, which plays a role in nursing programs turning away otherwise qualified applicants. Can change this. Nursing education programs, including universities, community college, continuing education initiatives, creditors, the National Council for State Boards of Nursing need to strengthen nursing curriculum and expand the environment where nurses train to better prepare us to work with communities. A good example of an education program that has effectively prepared students to address social determinants of health across various disciplines, in collaboration with various disciplines, is in Topeka, Kansas, at Washburn University. In 2017, the university partnered with the Topeka Housing Authority to open the Pine Ridge Family Health Center. A nurse practitioner is leading the effort and leads the center, which focuses on providing care to the community members, many of whom have limited access to care. The university uses a community-based center as an educational forum for students, including those from the School of Nursing, with a curriculum that focuses a wide range of topics, from social justice to trauma-informed care. The center is also a dedicated training site for nurse practitioner students, giving them real-world education and clinical practice in addressing the social determinants of health. Another good example is at the University of Texas Health Science Center in San Antonio. This school of nursing views health and healthcare as an act of social justice. And here, the students, many of whom come from the community, go there to give back to it. The School of Nursing's dean has worked with the Vice Dean of Practice and Engagement to create nurse-run clinics in the city's public housing development. With a HRSA grant, they opened a managed health center that educates interprofessional students about social determinants of health and has formed a partnership with the largest Medicaid managed plan in the state to support mobile health initiatives for families in low-income housing. The dean has also opened an on-campus pediatric health center managed by faculty from the School of Nursing, and many of the center's patients participate in this center, and many of those patients also come from foster care within the area. The School of Nursing attributes the success of this program to several factors. One, a diverse cadre of faculty that are committed and believe in community service, engagement, and partnership. Two, having this criteria as part of faculty promotion and tenure, having that have equal emphasis as that of scholarship as research. Recruiting and retaining students from the local community, forming strong relationships with the organizations, having a supportive university environment, and having a funding, sort of a reimbursement plan for this work. As the past year and a half has illuminated, natural disasters and public health emergencies disproportionately affect people of color, those with low income, those experiencing housing insecurity, and those with limited access to healthcare and transportation. Nurses serve on the front lines of these emergencies, helping people and communities recover. But nursing education, healthcare, and public health systems do not always educate, equip, prepare, and support nurses for doing this work to the extent that we should, and particularly not always through a health equity lens. Nursing school curricula vary and do not always teach about emergency preparedness. The major threats to global human health, such as climate change, air pollution, influenza, emerging infectious diseases, vaccine hesitancy, often receive minimal coverage in nursing school curriculum. Students who have learned about this topic report low confidence in their competency. Public health and school nurses with these community engagements activities like disaster planning, community response teams, helping families compile their own disaster preparedness kits, and advancing the preparedness in at-risk populations are something we could do as part of our clinical training, getting outside of the tertiary care facilities and into the communities. Nurses could also apply their non-clinical skills in networking, communications, creating partnerships, resource identification and assessments, as well as our understanding of social determinants of health that has resulted in increased vulnerabilities during natural disasters. Nurses also need to take care of our own mental health and well-being. However, many of you know, the systems where nurses learn and work must do more to prepare and support us so we can in turn support the well-being of others. As the COVID-19 pandemic has starkly revealed, responding to crises takes a serious toll on everyone's mental health and well-being, but especially healthcare workers and in this case, nurses. Nurse well-being is a cycle that affects all aspects of our work. Truth is that nurses were experiencing a well-being crisis well before 2019. Estimate rates of nurse burnout ranges from 35 to 40%. Nurses experience a higher risk than the general population for suicide. There is an expected culture within nurses in which nurses or new nurses routinely encounter bullying, intimidation, hostility, and even hazing from other nurses, staff, managers, and supervisors. Nurses who work in long-term healthcare settings face stressors such as physical and verbal abuse from residents, often residents perhaps with dementia and exposure to death and declining health. This can cause compassion fatigue. Nurses of color experience discrimination and bias within the workplace and educational settings. compounded by the lack of diversity among the nursing workforce and faculty. Some universities have taken steps to address this challenge. For example, the University of Virginia School of Nursing's Compassionate Care Initiative serves students, faculty, and staff, and promotes wellness in a number of ways through coursework, resiliency activities, workshops, retreats, meditation, yoga classes. They conduct research on things like compassion, resilience, and self-care, and have ambassador programs that include student clinicians, faculty, and community members to share in the successes and challenges of the program. Associations and other professional organizations have taken steps to improve, promote, and advocate for nurse well-being. The Pathways to Excellence program, an initiative from the NCEAS, recognizes healthcare organizations that demonstrate a culture that fosters a work environment to promote well-being. Institutions that meet the 12 standards focusing on workplace excellence are seeing improved patient care, decreased emotional exhaustion, and higher job satisfaction. The National Black Nurses Association also has an NBNA affirmations webpage in which nurses can share favorite quotes or positive affirmations. And the National Association of Hispanic Nurses conducts educational programming that includes webinars focused on stress and compassion fatigue. The report recommends that educators and employers should take a number of different approaches to nurse well-being. Number one, nursing education programs need to strengthen our curriculum and expand the environments where nurses train to prepare nurses to work with communities to advance health equity. Federal agencies, employers, and nursing schools must strengthen the capacity of the nursing workforce to respond to public health emergencies and natural disasters. The CDC, for example, could and should establish a National Center for Disaster of Nursing and Public Health Emergency Response, something that many of our disaster preparedness experts in nursing have called for quite some time. Employers need to support nurse well-being so nurses can in turn support the well-being of others. This includes staffing. This includes looking at your environments for bullying and harassment. It includes nurse well-being and nurses' rights, just as we have patients' rights in hospitals. All of these types of advocacy and evidence-based interventions must be dedicated to fostering nurse well-being. And as I mentioned earlier, within nursing itself, racism, discrimination, and dehumanizing attitudes from employers, educators, managers, and colleagues are omnipresent. The committee urges schools of nursing and nursing education leaders to commit to dismantling interpersonal and structural racism within their own institutions by 1, changing curricula which have historically focused on contributions of white and female nurses. 2, having difficult conversations about privilege and power. 3, dismantling long-standing exclusionary traditions to exclude some groups over others. Understanding how interpersonal and structural racism shapes the student experience. And reviewing and detecting biases in the curriculum routinely. Students can often help identify this, and we very much encourage them to be part of these review processes. The final action I'm going to cover today is the urgency of diversifying the nursing workforce. To better understand the changing needs of the nation, it's critical that the nursing workforce reflects that of our country. And when we discuss diversity, we mean diversity in all forms: race, ethnicity, gender, sexual orientation, geography, and more. Over the past decades, the nursing workforce has steadily grown more diverse. But let's face it, still a very white, very female profession, much like I'm talking to you today. But progress is worth noting. For instance, the nurse practitioner field has become more racially diverse since 2008. The number of white NPs has dropped, while the number of nurses of color has increased. Despite this progress, we still have a long way to go for nursing to accurately reflect the diversity in the community it serves. The latest data that racial and ethnic minorities account for 40% of the population, but account for only 20% of the workforce. Why is this? The report lays out a number of reasons. There is still significant cost, cultural, societal, and awareness barriers that prevent people of color, those with low incomes, first-generation college students, and others from pursuing the field of nursing. Particularly, it may deter them from pursuing advanced degrees. Nursing program faculty are also overwhelmingly white and female. 90% of nurses in formal leadership positions are white. Currently, these faculty are not all prepared to educate students about the societal determinants of health and health equity. Providing a pathway to nursing education for diverse students well before college is also key, particularly for first-generation college students. To start building a pipeline, this recruitment can start in middle school and high school. A great example of this effort is the Rhode Island Nurses Institute Middle College Charter High School in Providence. This is the first charter school dedicated to nursing and the first nursing middle college in the United States. It was launched in 2011 and the first class graduated in 2014. Its mission is to prepare students to pursue a nursing college major immediately after high school. They provide a free 4-year nursing-focused high school education for any student in Rhode Island. Students graduate with real-world work experience as well as up to 20 college credits. This has impacted the diversity of the nursing pipeline in Rhode Island. About half of the program's participants are Latinx and 1/3 are Black. Many come from underserved or low-income. The school has agreements with multiple colleges in Rhode Island to offer students a direct, affordable path to a career in nursing. Nearly 3/4 of the program graduates enrolled in college within the first year of graduation, and 79% did so within the first 2 years, compared to 52% enrollment for economically disadvantaged students in New England. A similar program has been developed in Albany, New York. To make sure that underrepresented or first-generation college students stay in school and have a positive experience, a number of schools have created programs to bridge high school to college. The University of Cincinnati hosts a summer bridge program to support those going from high school to college. These students have found higher GPAs and higher retentions throughout their first year. The RAIN program at the University of North Dakota provides a workshop for American Indian students to connect. Tribal leaders attend and participate in discussions about cultural and family values and issues. The RAIN program provides mentoring to American Indian students. Staff and leaders are heavily involved in the local American Indian communities, and many of them are tribal members themselves. This report recommends that if we want to diversify the nursing workforce, nursing schools need to intentionally recruit, support, and mentor students from diverse backgrounds to ensure the next generation reflects the communities we serve. Nursing accreditors can also play an important role by requiring standards for student diversity, just like they do in other health profession schools like medicine and dentistry. The systems that educate, pay, employ, and enable nurses have a lot to do to support nurses in advancing health equity. But it's important to recognize that there are things nurses at all levels can do to contribute to this mission. Nurses at all levels, in all settings, need to leverage our power to advance health equity by making sure we are prepared to bridge medical and social needs, take care of our own mental and physical health so we can care for others, and advocate for policies that address poverty, racism, and other conditions that stand in the way of health and well-being. National nursing organizations also need to work together to advance these report goals. In 2021, we need to start a shared agenda for addressing social determinants of health and achieving health equity. This agenda should include explicit priorities across nursing practice, education, and health policy engagement. Nurses can learn about social determinants of health and health equity both in classroom and through real-world experiences. For nursing, what are some ways that you all perhaps can prepare yourselves to advance health equity? Thinking about the ways in which you can in your community, your units, and your schools are really important. One example that we've had lots of people bring to us through our webinars and community events was the Community Action Poverty Simulation that has been shown to help nurses and other health professionals build empathy through these types of simulations. It can positively impact attitudes towards poverty and empathy among nurses and nursing students with the goal to break down stereotypes, allowing students themselves to have a simulated real life situation or real world experience. There are lots of other opportunities that we have found or that have brought to us through this report. Lots of people have engaged with this report, giving us many of the examples that we've brought forward here. This is just another one that I can offer you, the Mind, Body, Strong, adapted from the COPE, or the Cognitive Behavioral Skills Building Intervention, is delivered by a nurse to new nurses. It's comprised of 8 weekly sessions focused on caring for mind, body, and building skills. And again, here are sort of some other ones. Nurses at all levels and in all settings can advocate for building communities. We can join committees and councils. We can leverage our experience and knowledge to give voice to these issues. We can help lead to achieve health equity. In this case, 2 nurses in Baton Rouge have worked with the city's mayor to establish a community group, the Healthy Baton Rouge, to address food insecurity and obesity and isolation. We have a lot to do to support and advance health equity for all, and I do hope our conversation today has helped you see the path that we've aimed to chart over the next decade. What I want to ask of you today is, what can you do to help advance health equity? From a policy perspective, what can policymakers do to support nurses in an expanding scope of practice from the state and federal level? How can we provide more funding to school and public health nurses? How can we help advocate for investing in disaster and emergency preparedness infrastructure? Talk to your legislators, write, tweet, get on committees, talk to the people that have legislative abilities to move these policies and laws forward. Many of you all probably seen the American Rescue Plan and the many, many dollars that have been put in place for improving public health, improving school nurses, more loan repayment for nurses. Make sure you're in your communities and at your state levels to understand how that federal money will be dispersed to states. You all can be helpful in that. Healthcare systems, I'm sure many of you also work in healthcare systems, they can reshape how we pay for nursing services. Break down institutional barriers that prevent nurses from doing our jobs. We also need to make sure that these institutions support mental health and well-being among nurses, making sure staffing ratios, pay, and all of the various ways in which we collaborate, talk, and create environments that discourage bullying and hierarchies are important for nurse well-being. Public and private payers can reshape how we pay for nursing services while investing in more school and public health services. If you're an educator, you can foster a learning environment that are more inclusive and supportive of nurses from diverse backgrounds. You can strengthen your curriculum. You can take a hard look at your curriculum and try to expand the environment where nurses train, fostering well-being for the next generation of nurses and making sure that the next generation of nurses feel supported in the environments that they go to. And students, for those of you that are here, I want you to seek out opportunities to learn about health equity and social determinants of health. You can take on these leadership roles. We need you to be part of our committees. We need you to be part of our groups that look at our case studies and stand up when they reflect stereotypes that have bias and have discrimination and racism in them. Find the textbooks that may have places that need to be changed. We've had lots of students come and point out to us places in which even our most up-to-date nursing textbooks still have bias and discrimination embedded in them. Find them. Tell us. We want to change and we want to work with you to do that. Frontline nurses can make sure you're well equipped. You already know this, that you are well prepared to bridge medical and social needs. Taking care of your own mental and physical health and advocating for policies to advance health equity is something that we all can really look inwards and try to focus on for our patients. So I hope this has given you sort of a sense of what the Future of Nursing report is about. So these were some of the more recent webinar series that we had. So that's when they had happened. I know we're well into October now, but all of these have been recorded and go back to them on the National Academy of Medicine website to do so. You can find our podcast also, and you can explore all of our report materials there. In terms of my contact info, I tried to make sure that I put it forward for you all to make sure that you all had available in the documents that I provided early on. But in case you do want it, let me share my screen so that you all have it here. Thanks. There you go. So that's my email. Don't hesitate to reach out to find me. And I hope this was helpful. And we'll be taking some questions and answers. And you can feel free to email me them as well. Thanks again.
Hi everyone, so now we'll take some questions. If you just want to feel free to unmute yourself and ask any questions, go ahead.
I don't hear any, which is totally fine. I know a lot of people watch this on playback, so no problem. I did want to let you know I dropped the link in the chat for the podcast. So Claire, you can probably just send that out whenever the recording goes out. But it's the Future of Nursing podcast. So if you go to wherever you get your podcasts, Apple, Spotify, Google, wherever you get them, just type in the Future of Nursing podcast and you'll come up with an 8-part podcast series that is about 30 minutes or 30 to 40 minutes for each part of the series that I think you might find interesting and a really nice way of storytelling the Future of Nursing report.
Thanks. Yeah, I will include the link if anyone has any questions. Otherwise, we can.
It looks like there's one in the chat, Claire. So someone just asked, how do you discuss the public health issues as a nurse to lawmakers? It's a great question. I think there's a couple ways of doing this and really thinking about how your advocacy really does play a role, like a really important role in what legislators think about. And for those of you who are at the conference, we had an awesome legislator with us, and we talked a lot to Lauren Underwood about how important nurses are. So I'm just going to give you like sort of a rundown answer. So lobbying is something that I think a lot of us have shied away from in the past, but lobbying is simply communicating your views on state, local, or national issues to your elected officials. And by doing so, you make your voice heard and your concerns addressed. So I think one of the biggest questions is, how do you lobby, and how do you advocate, which is a little bit about, I think, what this question is. So for a private citizen, there are a number of methods to lobbying. These include face-to-face meetings, telephone calls, letters, emails, social media. Generally, the more personal the contact, the more effective. So if you cannot meet with a legislator, meeting with his or her assistant or aide is just as good. And so policymakers rarely have time to read all the literature on a specific question. And in your case, I think the question was around public health and nursing. And so in order to make sort of well-informed decisions, they often rely on really tightly written documents called one-pagers that you can often leave with you when you're done. And so if you're wanting to talk about public health issues like, for example, kids and vaccines and why it's really important to have them for kids, leaving some document with information that talks about some of the facts around vaccines, the sort of big conclusions, and then what you want them to do. So what is it that you're asking of the policymaker? Is there a specific bill that's on the floor you want them to vote on? Is there more funding that needs to be allocated in some direction? So what is the policy recommendation that you want to give to them is really important when you think about discussing public health issues to lawmakers. And never underestimate a good story. Nurses are good storytellers. We have lots of really good stories. And so make sure you sort of, when you are advocating for whatever the position is that you're talking about, discussing these issues with lawmakers and legislators, make sure you have a good story to go along with what you're trying to talk about, how it's influenced somebody in your community, in your hospital, in your clinic, the kids in the school. really go a long way, that legislators can often pair that with something that they're doing to really be more compelling to the constituents or to the people they're trying to get on board with whatever it is the policy that they're trying to work towards. It's a good question. Oh, I saw something else pop up. Oh, you're welcome. Sure. So Claire, I don't see any more questions, so I think we might be good to wrap up.
Sounds good. Thank you so much. And thanks everyone for attending. I'll send out the recording and information on via email. It'll be posted on our website as well. Probably by next week.
Bye, everyone.
Bye.